Thank you very much, Dr. Amta. We move on to the J&J session. First is Virender. Are you there? Virender, are you ready? नहीं था तो मेरे से. So this is going to be a deferred live surgery, and these surgeries have been pre-recorded. So there are going to be, as per the schedule, about 4 phaco surgeries with IOL implantation and 2 silk surgeries. So may I first request Dr. Virender Agarwal to show, I think you are going to show a phaco with synergy, right?
So
Virender, go ahead.
we would request everybody, if you have any questions, you can directly ask the speakers here and the people who have already performed live surgeries and have recorded it, and they are going to be playing it. So we are going to have a lot of discussion.
Gaurav, is Dr. Himanshu here? Okay. Gaurav?
Gaurav is not there.
नहीं मैंने कहा उधर होगा. पूछ लो मैं उनका. Actually, I don't.
Maipal sir?
Gaurav, is Mayank there? Is he going to come here?
I'm going to be able to join from here only, sir. आप लोग conduct करिए. Anything I need to be commenting on, I can do it from
comment
here,
is fine. I'm just asking. Mayank has to show a deferred live.
Mayank is going from here. He'll reach there in 15-20 minutes.
Oh, okay.
He's just left from here.
Okay.
Anybody else you need from our place?
No. I think
it is
Himanshu hasn't come. I don't know whether they have the video. Amit Garg.
Amit was here.
आप बेशक next कर लीजिएगा.
So
Yeah. So Virender Agarwal, as we all know, is a great surgeon from Jaipur, cataract and refractive surgery, trained at RP Center, then SMS, and now running his own private practice. So over to you, Dr. Virender.
Thank you, sir. Thank you, Dr. Namrata, and thank you for the AIS and the local committee for giving me this opportunity to share my experience with the continuous range of vision IOL, that is the CRV IOL from Johnson & Johnson, the Synergy. I'm just coming to the slides just
इधर डाल दो.
for the purpose that it has no limitation of the patients, like many people feel that the multifocal or the trifocal or the continuous range of vision cannot be done to the people who are active in life. He is a laparoscopic surgeon, and I just want to say that the synergy lens requires something which is different than the normal cases, or the multifocals or trifocals also the same. The dry eye is the main culprit for patient dissatisfaction, so it should be taken care. The macula should be healthy, the specular count should be healthy, because these are going to affect the quality of vision, and which we may blame on the premium IOLs, particularly the lens with the rings. So I am for the lenses with the rings because they give what we desire. And the important thing is that what is the patient need? There are times when we feel that the patient need is defined that he requires a distance vision. But we should ask him what actually he wants. If he wants all these kind of things, then it is better to think for synergy lens or a continuous vision range. And there are the reasons why the continuous vision lens performs better than others. You can see here that this range, which is a continuously there within the range where the patient can actually see. And this is the reason this lens is the first lens of my choice. There are other lenses which are trifocal, no financial interest, but you can see that these are falling beyond the range. The lenses are dipping in between, and this is why they are not into continuous range. They have 2 focal points, one for like here and one for like here, by which they give the near vision somehow, and they give some kind of the intermediate or a little distant vision, which they call it as a trifocal or 4 focal or 2 focal points. But here there is a mix of lens in which there is a multifocality and there is a continuity. The continuity was added by the Symphony, and the bifocal lenses were there with the Johnson already. The mix of these technology has brought new things, and there is a special SLS design, achromatic technology and violet filter. They are added to the quality of vision. Nowadays we are shifting to the area where you require more of a violet light kind of experience, where the patients are actually seeing more of violet lights because of the LED entering into it. I am coming to the actual surgery. I am little slow surgeon, so I'll play it on slightly speed, so you don't get bored. And the surgery is almost the same. You all can do the good surgery for cataract. The only hitch is that we think that the multifocality is not a good thing. The patient will be after you that why you have done some lenses which are having rings. The majority of the patients are monofocal, so their experience of the peer pressure or the peer experience is that the monofocal is the best lens. Here I will request and at the same time suggest you all, those who are not doing multifocals, please shift on the multifocal. This is the time where the patient wants independence from the glasses. Cataract is become the refractive surgery. Initially we wanted just emetropia for the purpose that they should be off glasses for distance, but now the demand is that patient should be off glasses for all distances. I am not against the EDOF lenses, but till now the EDOF lenses are not able to perform to the patient expectation, except that they are not having rings. It is not the rings which is blocking the thing, it is the thing that we feed in the patient's mind, that we say because the rings are there, you will have some difficulty in driving or some issues. So this is a routine phaco which you all can do. So I will take it slightly forward, or I will increase the speed here. So the required thing for phaco is that you should have good biometry. I prefer to do optical biometry, and where it is not possible, do immersion biometry to have more power accuracy. You need to know your SIA, you need to give importance to the cylinder. These lenses are very sensitive to the residual cylinder more than 0.5. So your aim should be that the post-op cylinder should be less than 0.5. And if it is not so, think for LRIs or toric lenses. The cases where you don't require to manage the astigmatism, they are the simpler cases. The another thing which I am going to come, Dr. Namrata was saying that the bimanual becomes slightly slower. I think it is not the same case for every case, because the port size can be done increase in the bimanual also. I have designed one particular bimanual where it is very, very fast, and I use initially the polished bimanuals. The ambidexterity and complete cleanup is very effective and easily done with the bimanuals. Coaxial, those who are master can do the same kind of job, but still the ease with bimanual for complete cleanup is definitely there. I use bimanuals with the polisher, and because of that polisher effect, I can remove all the capsular cells, fibers, or whatever is there in the PCO. PCO is the main culprit for the dissatisfaction. The another thing is that. So the culprits are that effective lens position to have the actual power, emetropia, and the another thing is the PCO. These lenses are very, very sensitive to posterior capsular opacification, because as we know and say that these lenses causes some diffraction which is not wanted. And the PCO also to start with causes the diffraction only, and added diffraction which is not planned, which is not very organized in the sense that is not having a definite pattern, it is difficult to have adaptation. The another thing, PCO keep on increasing later on, and that affects the quality of vision much more than that. At the same time, the expectation of the patients with the synergy or multifocal, trifocal, etc. are higher than the other patients. So you require to deal with the PCO management early. I prefer doing this polishing and giving enough time to do a polish. It just takes your 2 to 3 minutes extra to do a complete polish cleanup of the capsular bag to avoid PCO. Though many people said it is not affecting much, but I feel it is having a very good response, because almost all patients are not requiring a YAG capsulotomy. It is not the only reason. The lens design, square edge, material, the placement, the capsular size, capsular axis size, these all are having importance, but I think doing enough polish gives you safety that patient quality of vision will be maintained for a longer time. Now I comes to the why I use CRV over the bifocal, trifocal or other kind of lenses. The reason is that I am using multifocal lenses since almost now 30 years, and all sorts of lenses which were there even with the PMM also I tried, because since beginning I was in the belief that if multifocal lenses can be adjusted, suited or tolerated by the patient, it is the lens which to be implanted into the patient's eye. And there are a lot of development have happened. Initially we started with the refractive lenses, now we are diffractive lenses, and with the diffractive lenses by manipulation different things, the CRV is almost to the level where the quality of vision and quantity of vision is very good and patients are satisfied. Let me share you my experience that I am implanting these lenses even to the patients who are told by somebody else that because of the rings your life will be hell, but it's not so, they accept it. The only thing I differ from other doctors, they said that you have to tell them what is he is going to expect or see. So I tell them that if you want a freedom kind of thing after surgery, you will have to bear something that when you go on the roads, you will see lights and they will be having rings. If you tolerate them, you will have a good vision for distance, near and everything. Over the bifocal, the lenses are very good. They give one good near vision, one distance vision. But now, because of social media and other teaching and learnings, the patients are more aware about that they require an intermediate kind of vision, and that is how they have development of trifocal lenses. The trifocal lenses, they give 3 points, but still the patients are not very comfortable, and particularly my experience for the Indian eyes where their arm length is slightly smaller, the third point doesn't come into picture, and the near point is having a different kind of expectation and understanding, because sometimes if it is too near, then patient says I have to hold it here. When it is away, then he says I can't keep it like this. But with the CRV lens, the range is like this, and now what I do is that I ask the patient to hold at their distance and start reading, and very rarely it happens that they have to do some adjustment. And in all bifocal lenses, multifocal CRV lenses, I tell patients that the one eye is to be done and second eye should be done early. There are many patients who ask questions that if we don't have a cataract, why should we go surgery? So we say, or I say, particularly our counselor says that if we are not tolerating rings, we will do the surgery early. If you are tolerated to it, we will not do the surgery very early. And that is how my patients are happy and I am happy. Thank you very much for this opportunity. I am happy to answer questions if you have any.
Thank you, Virender. I think that was a very nice presentation. Sir, what is your take on this? When would you do surgery on the fellow eye if you've already operated one eye?
No, fellow eye, I would give the least amount of time. I have still not switched over to bilateral simultaneous surgeries, but in these trifocal lenses, see, as long as the patient has a different kind of a vision in one eye as compared to the other eye, the rings or the perception of dysphotopsias are more. So normally I would prefer to keep the gap the least.
Thank you. I think we move on to the next. Anybody would want to ask
any
anything?
other questions? So in any case, thanks. Yeah, go ahead.
I'd just like to ask, sir, do you do these lenses in very high hyperopic patients also, or do you do an angle alpha and then do the lens?
This is a very good question. I think angle alpha, kappa and all other things are having more hype than actual things. So angle alpha, we thought of that the patient will not see the thing. I will tell you the other way around. I will tell you the patient, you see the pupil and you see the lens after implantation and ask the patient to read, they are 6, and 6. And their lens is only having 2 or 3 rings coming into the pupil area, not even having that center kind of thing into it. So the patients who are having an angle alpha will also have that kind of deflection, but they are not getting visual complaint practically. So my take home is that the angle alpha and kappa are now not required to be measured for these kind of lenses.
No,
that is one thing.
I think, Virender, your personal experience may be a little different, but
I know science is different,
I know that,
but what I am saying is the
we all
patients
say-
are happy.
we all say that for these lenses,
So
they are
all the
important.
patients, I will say,
Yeah.
all the patients who
So
operate
I will,
upon,
no,
Dr. Mamta, let me complete, that there are many patients who have nasal shifting of pupil with the age, and down the line 5 year, 10 year, also they are happy. So what I am saying, that they require a vision. Second thing is they are having some kind of dysphotopsia or light disturbances. If you tell them beforehand that you will have some compromise, then the monofocal lenses,
then they are
that
more-
goes into their tolerance
they-
level and they don't have complaints.
So Amit, can we start your presentation, please?
Dr. Rajesh wants to speak.
I just wanted
Yeah,
to
yeah,
add one
Rajesh.
thing, and
Sure,
that
sure.
was that the current generation lenses have a larger central ring. That's why the issue of angle alpha has gone down. Earlier, the central ring was smaller. So even a angle alpha of 0.5 used to create a lot of problems. But now the central ring is more than, say, it is close to 1.2, 1.3.
1.2
So
to 1.8.
0.5, 0.6 of angle alpha is manageable, and people don't have much
So
problem.
At the
suffice
same
to
time,
say,
asphericity is the basic platform. Initially, the platforms were not aspheric.
The basic
Now
idea is
platforms are
that the
aspheric.
rays should not fall on the diffractive steps. That's
yeah, so
Yeah.
this lens is, apart from being aspheric, is an achromatic lens,
Yeah.
which I think should also become a standard of care over time. The only thing I would say is that as long as there are rings, there are going to be issues like angle and this, that, every discussion is going to be there. So I'm keenly looking forward to lay my hand on their next generation Pure C, which is a refractive lens with no rings.
No rings at all.
So I think.
Good
yeah,
afternoon,
go ahead.
everyone. Thank you, AIOS,
Thank
UKSOS, and J&J to provide me this opportunity to present this deferred life surgery. The patient details are, it's a 50-year-old female, blurring of vision from 6 months, diabetic, moderate NPDR. I'm planning to implant a enhanced monofocal. IANS is my first choice. Video.
Can you click on the link? Yeah.
These days, patients' demands are refractive surgery, not the cataract surgery. At times, it is not possible to provide trifocal or multifocal lenses just because of the suitability of the patient or the financial constraints. I usually do Trefine Blue in almost all my cases and intracameral phenocaine in the topical cases. Then this, I always hold the globe with the dialer in the topical cases, and Rex is around 5 mm, I prefer with the cystitome. Then the meticulous hydrodissection with the Cheng's cannula is a must. For the beginners, I must say that meticulous hydrodissection and the rotation of nucleus is must, because the freely rotated nucleus will make your life easy, and the steps after that are very comfortable and simple. So this is the Cheng's cannula. It helps me the hydration beneath the incision. And after rotating the nucleus, I start my cataract surgery. My preferred technique is stop and chop. Many of us prefer that, and few prefer the direct chop as well. In the stop and chop technique, I prefer to go for a trench, deep trench, and then horizontally move the nucleus. These days, machines are so good, you can go for a high vacuum surgery, fast surgery, and the fast surgery will be possible because the AC maintenance is very good. Surge is almost negligible. So nowadays, learning of surgery is not that difficult because of the high-end machines. I prefer to have emulsify one piece so that I can have a space to move around the nucleus. Then it's just a routine phaco. Everyone see regularly and doing it regularly. I prefer to use a chopper just beneath the cornea so that the pieces will not hit the endothelium. IANS lens is one of the best advanced monofocal lenses we have, and we can reduce our chair time, and the burden of expectations are also less. Because of these, I think the Indian multifocal lenses are implanted less. These EDOF are there, trifocals are there, but advanced monofocal decrease the requirement of Indian multifocals. As the irrigation and aspiration, I prefer coaxial, because coaxial is easy to use, but some incisional cortex definitely is a difficulty. That will be more easier with the bimanual. For the beginner, I must say, if you go for a coaxial one, you should go underneath the incision first, because it is easy. The chamber is filled with viscoelastic, and it is easier to emulsify in the subincisional area. Cortical removal, meticulous is must, so that the PCO rate will be less. Definitely, coaxial is faster than bimanual in my opinion. And you can see it's like sticky, slightly sticky, because of a diabetic patient. And in the end, I am unable to remove partly cortex at 10 o'clock. My senior told me better to be safe than sorry, so I left it. I'll remove this cortex once I implant the IOL because at that time the base is IOL, not the PC. IONS lens is definitely a good lens if patient want spectacle dependence. Basically, what I counsel the patient, when you require the lens, it is good to go for IONS lens because bilateral implantation can go from N12 to N8. The lens loading is very easy. I prefer to load this lens, both the haptic above the optic, so that the implantation will be easy. And this is so smooth delivery of the lens. These days, toric lenses are also there in this category, and they are also very stable. This lens is on the Technis platform, so the optical quality is equivalent to the Technis one. Now see how smooth the entry of the lens, and both the optics are above the haptic. I use dialer for the trailing haptic to go inside. Now I will remove the meticulous viscoelastic removal and the residual cortical matter under the base of the IOL, so that I am safe, and remove the viscoelastic beneath the lens also. Then we will go for the hydro, and that's all. Any question, I will be happy to answer that. Thank you.
Thank you, Ajay. I think that was a very nice demonstration again.
Thank you, ma'am.
Of the deferred life surgery and the use of the intraocular lens, as well as all the steps again very nicely shown. If we can move to the next surgery, that is Dr. Mayank Pankte is there? Sir, I think I would request Dr. Mahipal Sachdev to show his deferred life surgery on silk, the ultimate in the CLEX, that is the kerato-lenticular extraction techniques.
Thank you very much, Namrata. I'll be just, is the audio on here? I'll be talking about the Elita, showing you a live surgery there. So, Elita is the new platform, as you all know. That is the new platform for the refractive procedure. And it is a femtosecond laser, and this femtosecond laser essentially
will be trying to show a silk procedure on a young, bright 24-year-old girl. Let us come to the parameters. You see that we have fed the parameters. You can feed the parameters of both the right eye and the left eye together. The right eye is tick marked, so we are going to be working on the right eye first. So the patient has a manifest sphere of minus 2.75 and a manifest cylinder of 0.75 at an axis of 100 degrees. As we went along in the trials of the silk system, we adjusted the nomograms, and we have now overcorrecting the sphere by minus 0.25 as also a small percentage of the power. Similarly, there is a 10% overcorrection in the cylinder. So you can see here that minus 2.75 we are overcorrecting by 0.53, and the cylinder adjustment is 0.08. So the total correction is minus 3.28 with minus 0.83. Similarly, if you look at the left eye, it is minus 3.75, overcorrection of 0.55, 0.08. So minus 3.55 minus 0.83. This is the K1, K2. And if you come here, this is the optic zone, which is 6 millimeter, and the total treatment zone is 7.6. We are keeping a cap thickness of 110 microns. There is a flat ad, which is 20 microns we have kept. This is a 60-degree side angle cut, and you can see biconvex lenticule, residual bed thickness 342 microns, and the total thickness of the lenticule is 87 microns. So we are ready to do the procedure now. So first of all, we will be putting the speculum onto the patient's eye. Open the eye like this, see that the exposure is adequate, the nose should not be touching, and the cheek should be fine. Chalo, we'll just wet the cornea. Okay, we'll wet the cornea. Now this is the patient interface. You can see it has two pieces. This goes onto the machine for the suction, and this will go onto the patient's eye for the grabbing of the eye. So this is attaching onto the machine. This is the second piece that is there. This you can see goes to the undersurface on the patient interface. Once it is attached, we will just wet the cornea again. You can see here, so we have marked the 0, 180, and now we are applying the suction. The patient interface has been scanned. You can see patient interface was scanned, and now you can see we come onto the center, bring down into the green, which is about 20 or 30, and once we are in the center, you can see the pupil. We'll just open the grabber, just show the grabber. You can see that. So we are going to center now, center on the pupil. You can see the 0, 180 alignment. This you can do a cyclotorsion. There are the marks. So we are doing an alignment at 0, 180. There was no cyclotorsion. Now we are ready to fire. Ready?
So
Don't
this
move.
allows you centration
You
and
press the foot
cyclotorsion
switch.
after
It
docking.
takes between 16 to 17 seconds. You can see this is the undersurface of the lenticule, round cut, top surface of the lenticule, as you can see, and then this is the entry cut, which is 3 millimeters. So this is the end of the procedure. The machine will auto undock and move up. You can see this is the lenticule at the end of the procedure. So now you can see that the machine is auto undocking. So we'll just move the head a little bit now, open the eye, put a drop of local anesthetic. You can see we are attaching on the undersurface the new patient interface. So this has a soft silicone tip, as you can see, which will make it more gentle on the eye. Just taking the lashes out of the way and putting the speculum. Patient interface is being scanned, as you can see. The patient scanning is completed. Once the scanning is completed, that shows that the patient interface is good. This has been attached onto the machine. Open the eye now. Don't leave dry spots on the cornea, so just wet. You can see here, we are just taking it out. This is the patient interface. You can see silicone sleeve. You can see these marks here for the alignment on the cyclotorsion. Now we have centered it. You can see that scleral show should not be there, much suction on. So we are moving the bed up plus the gantry down. Go in. Once we are in the center, you can see green part. Now we'll open the grabber.
That's how you
Once we have
let the
opened
whole
this,
thing
the
fall.
whole thing has docked and it has come down, and we have got a 10 millimeter applanation. Now we are centering it. You can see cyclotorsion slight bit. You can see 4-degree cyclotorsion. So we have got good alignment at the 16.7 seconds biconvex lenticule that you have. Press undersurface of the lenticule. You can see round side cut, top cut. This is the cap cut, as you can see. This is the entry wound now, which is 3 millimeter. Goes over it several times, so there is no problem in going into the entry wound. This is the completion. You can see this is the lenticule. Now we will shift the patient onto the microscope area. You can see that the bed is moving. Now you can have the bed which is below the microscope that we are going to have. Okay, so you can see now we have the patient under the microscope. Okay, so you can see that there is a green blinking light and a red light which the patient is asked to see. So we'll go in. You can see that with this is a slide pointed. I don't use a forceps, but you can see this is the entry. Now we have to go up, okay, because it's a biconvex lenticule. We go up like this. So this is the anterior part. Now we go below. So this is the posterior. Now let's see this. This is what is called as a stop sign. You see there is a resistance here because we are in two different planes. Now this is the white ring which you can see, which is the white ring sign you can see here, and you will see the meniscus sign also, that when we go into the posterior lip, you will get a meniscus sign. Now we are just going up. You can see this is a blunt spatula. just going up. You can see this bubble is clearing up. You can see there is no lift of the posterior lip. Okay, so there is no meniscus sign because we are on top of the anterior part, as you can see. So this is the separation of the anterior part. Now just watch carefully. This is posterior. So can you see a meniscus sign here? So this is like a lip that is created. So this is a meniscus sign. You can see there is virtually no dissection. This is again the meniscus sign on the lower part. So you can see this is absolutely effortless. Because it's a 1 micron contiguous spot, you can see that there is no separation that is required, and you can see one side has been dissected totally. We go to the other side and this is totally dissected. No cutting, nothing, because it's a blunt dissector that we are using. And you can see here that this is the lenticule. Just pull it out. You can see that the lenticule is pulled out. We'll just see that the lenticule is complete. For beginners, you should see it. I normally don't because I know that I have removed it totally. You can see this is a complete lenticule that has been removed. Absolutely. If we measure it, it will be the same measurement that we had, which is the 6 millimeter, which is there. So you can see this is the lenticule which came out in a single piece. The chances of retained lenticule are almost zero if in case you have followed the proper dissection technique and you have kept the cornea moist at the time of the laser firing. We'll just massage out the fluid, and that is the end of the procedure. So we'll call the patient in the morning tomorrow to have a look. The patient is under topical anesthesia. Patient is comfortable and the patient just walks out. There'll be an examination outside on the slit lamp to see if the things are all right. So with the end of the procedure, we'll be open to questions. If you have any questions, I'll be happy to answer. But before we do that, I'll just want to highlight a couple of things. It's a fast laser. It has a very high repetition rate. It has only 1 micron spots, and therefore the time for which it is firing is very small, and the total energy that is released on the cornea is very small. As compared to a 4 micron spot, this is only a 1 micron spot. It is contiguous. There is no line and spot separation. So what is the advantage of not having any line or spot separation is that you do not need any dissection, as you have seen in this particular case. There is no dissection that is required. It moves over the entry wound and the side cut several times, so that there is no issue in getting the entry wound and the side cut entered. You saw I did not use any tooth forceps etc. to hold on to the eye, because patients feel the pinch of that, because the dissection is not vigorous. It's just a kind of a separation which is required there. Now the other thing is, it is a biconvex lenticule, and as you all understand, optically a biconvex lenticule is going to be better than a plano-convex lenticule, and it has been shown that the higher order abrasions are much less in a biconvex lenticule as compared to a plano-convex lenticule. The other thing is, it is a fast laser. The third thing is that because the nerves are entering from the periphery and you have a biconvex lenticule, so because it goes into the cornea a little later, that means the cut of the lenticule is not a plano and it's not at the edge, because there is a convexity. So therefore the incidence of dry eye is also less in this particular case as compared to obviously LASIK, but as even compared to a plano-convex lenticule procedure that is being done. So these are a couple of things which are important. The suction is pretty tight in this particular case. You can do a centration and you can do a cyclotorsion compensation, so that also helps you in getting accurate results. So we are, because dissection is very little, as also the amount of energy that is put on the cornea is very little, so that the corneas are quiet the next day, and most of the patient, almost all of the patients are nearer to 20/20 or 6/6 next day. Thank you.
Thank you.
Thank you, sir. I just had a question for you. You worked on both the platforms, the Smile as well as the Silk platform. So, number one, how do you counsel the patient which one to choose?
I've shifted the Smile to Gurgaon. So,
And number
that's
two,
the advantage of having multiple centers. But yes, I have a tendency to counsel the patient more towards Silk.
more towards
Because
Silk. And
of dry eye and biconvex lenticule and centration, because I have the 500, 800 I think cyclotorsion and centration you can do, but here we
in
had
terms
right
of
one.
in terms of visual results, do you find any difference Or did you find any difference in the
So,
post-op vision?
Namrata, to begin with, I would say that again, when we started even with the smile procedure, the energy settings, for whatever reasons, the company would say put it at 36. Today, I think you guys also must be using in the 20s, upper 20s or something like that. So, less energy on the cornea means faster visual recovery. So, here also we started about 50. We have come down to 40. And I can't go below 40. And I think our next phase of trials would be to also have a line separation first and then a spot separation. So I would say that the results are pretty good. If I don't get 20/20 in my patients next day, I am surprised or I am a little concerned. But from overall, the patient acceptance is pretty good because you can center, and in lenticules, by far, if you're cutting a 6 lenticule, whether it be silk or smile, it is a 6 millimeter lenticule. While if you do a topography post an excimer ablation, a 6 would be ideally like a 5.5 or something like that. So I am happy with both the lasers, but I am tending to go towards the silk procedure also because I've been associated with the trials right from 2018 and being the first surgeon to perform any silk procedure globally, so I do have a bias towards silk.
Also, I wanted to know, would there be any situation where you would rather go for silk, smile rather than for silk?
Oh, tomorrow if they come out with a hyperopia, then there's there. Apart from that, I don't think there are two issues. One is if you lose suction in between, which is very rare in silk, because it's a biconvex lenticule and both are refracting surfaces, so you cannot recut at the same time. So you will have to either make it into a flap or a PRK or do it later. So that's one disadvantage. The second disadvantage is we don't have a circle scan so far. So these are the other things, but I don't specifically would say. The only disadvantage I would say is that just now, because it's a two-piece PI, the PI is larger. So in very small eyes, docking is easier in smile as compared to silk. But on the contrary, once you dock, you don't lose suction. So even in the best of hands, the suction loss is about 1% or something. Now with the newer laser, I think the time that is taken with the Smile Pro has come down. So this is about 16. This is in between the time that you took with Smile versus Smile Pro. So I think suction loss has come down with the Smile Pros, and silk also we don't get suction loss. But I think the only one thing is the deep set eyeballs or smaller this thing can.
Yeah. Mohipal, what is the maximum diopter that
Maximum
can be
is
corrected
12.
by this procedure?
Maximum is -12. Combination of sphere and cylinder. So you can do like a -6 with a -6. Okay, the maximum cylinder you can do is -6. And but the combination of two powers put together is -12.
That means what is the minimum that you will leave behind, thickness of the cornea?
I keep it the same. Normally, PTA I would see what the topography is, but I don't go below 275 in any case. I prefer 300, but I don't go below 275. That's my cutoff. So I have not changed my residual thickness or anything as compared to LASIK.
Thank you.
Because the evidence is still not crystal clear that biomechanically a lenticule is better biomechanically than LASIK, but it makes more sense to. I have been on lenticule now for last more than a decade.
Okay. Thank you, sir. I think
you.
we'll move on to the next talk. The next talk is going to be the next deferred surgery will be shown by Dr. Rahil Chaudhary. Can we have the link, please? And again, it is on silk. Meanwhile, as it is being started, one more question, maybe slightly uncomfortable in terms of economics or in terms of cost to the patient.
It's
sir?
not uncomfortable. The cost to the patient I have kept the same. From a surgeon standpoint, I think J&J is slightly better.
Okay, sir.
Yeah.
Refractive error to up to -12 in
No, that's
silk.
that's what it is. -12 including the cylinder.
Including the cylinder.
मतलब sphere
Whatever
plus
is
cylinder.
FDA approved or whatever.
वो तो
it-
उसमें भी कितना है? Smile में भी इतना है? Same है. I
Can
think
we
it's the
can we
same.
start the presentation, please?
मतलब I don't know उसमें कितना है? I think it is the same.
-10
Minus
and
12.
2.5 cylinder. If you add on 10, otherwise 12, the same.
It's
But
the
it's
same.
not like spherical equivalent.
But
In
there
the
is a small
lenticule, it is
fallacy. There is a small thing that you need to understand. I showed you the nomogram adjustment. The nomogram adjustment, you have to overcorrect. So basically there is a minus 0.25 with a 5% overcorrection of the whole thing. So technically if I am correcting 10, I have to feed 11. तो actually एक diopter कम हो जाता है. Even in the sphere and the cylinder, there is an overcorrection which we are also doing for smile. So that nomogram adjustment actually brings it down by about a diopter. So 12 would actually become 11.
So, next, can we start the next talk? Okay.
Yes,
So,
very good
Rahel, you
morning to all
are live, yes.
Yes, am I audible, ma'am?
Yeah, you are audible.
Yes, so very good morning to all the panelists and audiences sitting there. And I am demonstrating deferred live surgery for the Elita Silk, which is basically a lenticule extraction refractive procedure. So this is an unedited video and I'll explain step by step how the procedure is carried out. So first of all, because we don't have automated cyclotorsion in the machine as yet, but yes, it is going to come very soon. So at the moment, we are marking the 0-180 axis on the slit lamp. So this is how we do it. And before we do this marking, one very important suggestion that make sure the pupils are aligned. So when you're marking with the slit lamp, just move the beam one eye to another and just see that beam is dissecting the pupil perfectly and then do the marking. So usually I'm putting one mark that helps me with the cyclotorsion alignment on the machine. And now after this, we are going to shift the patient on the Elita machine. So in our setup, we have kept the machines separate. So we haven't put the swivel bed. So it keeps us the machines independent. So all three machines can be used at one time. And showing you the parameters. So we are taking a 6 millimeter zone for the correction and we are correcting about 5 of spherical with half a diopter. And for ease of demonstration, I'm showing you the left eye for the angle of recording. So this is now a 2-piece PI that we are using. We are expecting a single piece PI to come very soon. That would improve the comfort level for the surgeon. But I am very comfortable with the 2-piece PI because it gives you a better control on the eye. So putting onto the speculum, getting the eye ready. And now, when we have to start this procedure, the first step is to centrally align it. This is how the PI looks like. So it's a 2-piece thing which I mentioned before. So the first piece goes onto the cone and then you have this suction ring. And now with the Elita, this suction is automated compared to the previous machine where it was a manual suction. So now the machine is ready. Before we put onto the suction, make sure that the eye is clean and there are no secretion, mebum secretions present. So just wipe the eye once and you're ready to start with the procedure. So you put on the suction ring and start with the vacuum. Now the eye is in control and slowly move the machine towards the eye and it does just docks like magic. So there is absolutely no effort. It is very comfortable for the patient and for the surgeon. Once it is docked, you just pinch the apparatus and it applanates. And we are ready to move on to the next step. So now we do the basic adjustments. You have an overlay on the screen. So first we are adjusting the axis. So you can see this can be rotated and adjusted. And then we are doing slight centration. So some surgeons prefer marking maybe a pupil center or a visual center before. And later on, we are going to have automated centration in the machine. So that is going to make our work further easier. And so this you can see, this is a 6 millimeter zone that we are working on. This is your transition zone. This is the opening and the axes are aligned and we just press the pedal. It's about 17 seconds and the machine starts with creating the lenticule. So first the posterior part is created, then the ring is created, then the interior part is created, and then the final openings are created. So working on a 3.5 millimeter opening, it can be reduced to 3, But for beginners, I recommend to use at least 4 to start with. Now the lenticule is ready and we'll be shifting the patient under the microscope. So speculum out, sheet off, and now we are shifting the patient to the next bed. So I'm using the EX500 microscope to do the extractions and it works wonderfully well. So now this is the microscope view. And the first step is to open up the side cut. So for beginners, I recommend you make sure that the opening is properly opened. Sometimes you can have adhesions. So make sure you swipe the instrument side to side so that the openings are perfectly opened. Now we have to understand that this is a biconvex lenticule. So when you are entering the anterior plane, you have to tilt your instrument slightly upwards. If you go straight, you're going to enter the posterior plane. So anterior plane opened. Now you go straight and you open up the posterior plane. Now both planes are open. Of course, there are multiple ways to confirm that. One is the stop sign. The other is that you can see how the bubbles are dissipating. Now you go in on the anterior plane and just gently swipe your instrument side to side. And you can see how the technology lives up to its name. The dissection is extremely smooth with almost bridge-less spots and a small spot size and with ultra low energy. So once the anterior plane is dissected, just make sure you swipe your instrument end to end so that there are no adhesions left. Now you go to the posterior plane and you start separating. Now the beauty of this silk procedure is that you have little adhesions on the 3 o'clock and 9 o'clock position. So because of those adhesions, the lenticule stays in center and the dissection becomes easier. Now the lenticule is perfectly dissected. Now we go in with an instrument and we have to extract this lenticule out. So I recommend do not pull this lenticule straight away. Go in a circular motion. So in case if there are any residual adhesions left, this will take care of it. Now for the initial 100-200 cases, I recommend checking the lenticule if it has come out incomplete. But with experience, you know that the dissection is complete. So maybe you can quit the checking the lenticule. Now we are proceeding with the washing of the interface so that there are no residual, maybe sometimes you have lint fiber remaining inside. And now this step that I'm showing you, this is called ironing. And this is one of the most important steps. So to take care of any Bowman's folds that may encounter during the surgery. And now slight ironing, slight light sponge ironing, and the procedure is complete. So a drop of antibiotic and we are good to go. And this marks the end of the procedure. Thank you so much.
Thank you, Rahil. I think that was an excellent demonstration of the technique. Anybody has any questions? So what is the size of the incision, Rahil, that you actually keep for your...
I am working on 3.5 millimeter as of now. And with expertise, it can be further reduced to 3. But for beginners, usually it is recommended to start with a bigger incision so that the manipulation becomes easier.
Okay.
So this goes from 2 to 6.
Yeah.
Yeah.
Allows you 2 to 6.
Okay, so another question for you, and that is that you have done Contura quite a lot. So how do you counsel your patient what to choose, Contura or to choose silk?
No, I think now people are not coming in with Contura in their minds. Probably there are newer technologies coming in which is creating a lot of buzz by the name of Wavelight Plus. So now I'm giving options of a flap-based procedure, which is the Wavelight Plus technology, and a lenticule-based procedure, for which my preference is the silk procedure.
Okay. Thank you so much. Any question? Any other question?
No, fine, thanks.
What
Thank
is the Wavelight Plus? What does exactly the Wavelight Plus? What information does it give you?
Sir, it is a new technology launched by Alcon, which is based on a ray tracing principle. So they've just launched it about a month back, and we have got the first machine in India, and the results are coming extraordinarily well.
What do you mean
But
extraordinary? In the sense that first everything was extraordinary, so how extraordinary can extraordinary
So,
get?
we are seeing about 6/5 vision on post-op day one, and the technology claims to
Because
be
we used
vision
to
up to
get that
6/5
also in
Okay.
Contura. We
Okay.
used to
Yeah. So,
with
So
silk
see
is
that
a
the
little.
chances of getting a
okay, so
6/5 vision
thank
is
you.
about
Thank you.
10%, and here we have about
Thank you.
98%.
Thank you so much.
So,
Rahil, is
Thank
Dr.
you, sir.
Mayank Pangte here?
Mayank, yeah, thank you.
Mayank, can we
Thank
have
you.
you?
Thank you so much.
Rahil. Thank you
Thank
for
you.
that good case.
So I think we'll go on to Mayank now.
So we move back again to cataract, and Mayank is going to be telling us about. Mayank, what lens are you showing?
Right. Good afternoon all. I would be presenting eye enhanced implantation on a J&J platform, the new platform which is Veritas. Demography of the patient is he's an 80-year-old patient and has a grade 3 plus nuclear sclerosis, high myope with lax zonules. Surgery is being done under topical anesthesia, and I prefer to sit superiorly and operate temporally. So we'll be implanting a 19 diopter iron. This is an unedited video, and zoom and fast forward it whenever required. The main port side port is already made almost at 12 o'clock, and this is my temporal port. I prefer to make a 2.2 millimeter incision after enlarging it, or 1.2 millimeter incision. So this is a nuclear sclerosis grade 3 plus, high age, high myope cataract. So I prefer to use a viscose dye to stain my capsule. And I'll just fast forward it and remove the dye. Put in some viscoat and then HPMC under it as a soft shunt technique. With a 2.2 mm incision, I use the rexus forceps itself to create a neck and do the capsulorhexis. This being a bit harder cataract, I might have made a slightly larger rexus. I prefer to do a direct chop in my cataracts, and usually avoid doing hydrodissection and delineation in such cases. This is being done under topical anesthesia. So no hydrodissection, no hydrodelineation. That would be the sharpness of the chopper. Not doing hydrodissection in hard cataracts helped me fixate the lens better, and the direct chops are much more easier with the same. So see the thickness and the sharpness of the direct chop, my handpiece chopper. And this is a Veritas new machine from J&J. This is having much better fluidics and control, so impairing the superior quadrant. Unfortunately, we don't have the layover here. So now, since and there is no hydrodissection, the rotation would be a bit difficult to begin with, but I'll make a small side chop as well, and thereafter the small side chop, and after this my rotation of the lens will be good. A bit of lax zonules, that's why the chopping is a bit difficult. In the case, now the rotation is easy. You can see the lens is rotating easily, making further small quadrants. and slowly completing the multiple fragmentation of the nuclei. Despite doing no hydrodissection or delineation, we can easily have the rotation of the lens. And now my multiple chops are slowly getting completed. The new machine ensures you much better woundability and vulnerability of the lens. Small pieces have been created, and after this we'll take out one by one a single piece.
So Mayank, can we move a little faster?
Okay. And the vulnerability of the piece with this machine is good, and there's very little chattering of the lens. It's a 2.2 millimeter incision. Some degree of wound hydration is there.
So hydration of the wound is more than desired, Mayank?
Yeah, definitely. So last piece cataract, always put some viscoelastic before you take them out. And in these hard cataracts, you tend to have small pieces lodged at multiple places. We will find that even in this surgery, we thought things were clear. After this removal of this material, we found out after ion implantation, there was still a small piece redundant lying in the inferior pole. I changed my chopper to a blunt chopper. Remove the and skip the IA part and then go into the implantation. There's not much left for the irrigation aspiration. And now we'll be preparing the lens for implantation.
So which intraocular lens you would be using?
This is an Eyehance lens.
Eyehance lens. So I think Eyehance has changed the way we are implanting lenses now, because it is being advocated as a monofocal plus lens.
Definitely.
In our center also, the monofocal plus lenses have overtaken the monofocal lenses.
So this is a rotational screw-based injector, which gives a very slow and controlled implantation of the lens. And irrigation aspiration, and even after the screen surgical, we could find there was a small piece at 6 o'clock which we could ideally take it out from a handpiece, or in this case we took out with a IA handpiece itself. So we were actively searching for leftover pieces under the lens iris, and we found one, stuck it behind, which we gently removed with the eye. And that would be concluding the surgery. Thank you, ma'am.
Thank you very much, Mayank.
Thank you, Mayank. I think that
Yeah.
was a very nice demonstration of the
Doctor.
case.
Regarding
Hydrodissection. Hydrodissection
dissection.
should be done. What Mayank doesn't do is the rotation of the nucleus.
What is the reason, main reason for that he is not doing hydrodissection? Will it not make the life much easy and more safe and comfortable surgery and
Yes,
faster
I
also?
think, so Mayank, I think you
I'll answer
answered that, but you would.
So once the cataract is very hard, like it was here, so the entire cataract is one piece. So hydrodelineation is out of question. You will not be able to delineate it. A. B, once you are not doing hydrodissection, for such hard cataracts, the best technique would be a direct chop, where you would be catching hold of one side of the lens and use a sharp chopper, bring it towards it. If there is no hydrodissection, this step becomes very easy. There is no rotation of the lens during that step. And as you saw, once I made my first chop clear, then I made a small side chop. And once I made the small side chop, the entire nucleus was free by the movement of our hand
No,
chopper, and we could easily rotate the lens thereafter. Thereafter there was no problem.
It's not a question of hydrodelineation hard cataract. It's only a question of separating the whole, nucleus from the capsule. Hydrodissection. It will not give much stress on the zonule.
He is
No,
doing
not at all.
no hydrodissection. He is doing what he sometimes
He
defers.
says he doesn't want to do
You don't want to.
hydrodissection.
No, but
He's
in
not
very
doing
In hard cataracts, I would not like to do
in
hydrodissection.
Okay, so-
mature cataracts, you don't need to do it also.
Yes, because it's a one piece, everything is one piece. Once you started doing your chopping,
So Dr.
the
Khanna,
entire lens will move by default.
Mayank, that's
In
fine.
my opinion, I think I do hydrodissection very
So
nicely.
if you are doing
and rotate
stop
the
and
lens
chop,
minimum 2 to 3 times round the
so
clock.
if you are doing stop and chop or other techniques where you don't need much of the,
Even direct chop is much more comfortable with hydrodissection.
I think we can leave this discussion. Let's agree to disagree. A lot of people do hydrodissection. He doesn't want to do, so that's fine. But there are pros and cons. but the-
Another point, you sit superior and do the temporal phaco.
right, sir.
What makes it,
No, that's okay. Some people do that. They are sitting
आसान हो
superiorly,
जाता है
but they are doing temporarily. So that's
So
okay. Thank you,
if
Mayank.
you have
I
a
think.
broader chest, you can do that one.
Thank you, Mayank, for your